Hi, good morning. My name is Dr. Jason Waspy. I am the chair of New England CEPAC. I'm also an associate professor at Harvard Medical School, and I'm a clinical cardiologist at the Massachusetts General Hospital, where I direct our program in outcomes research. To start every New England CEPAC meeting, we'd like to first introduce each member of the CEPAC. And as part of that process, we want to ensure that all speakers disclose any financial relationships with industry. Every member of our New England CEPAC panel who is present today has met the ICER conflict of interest policy. So as I go through, will each New England CEPAC member please introduce themselves, maybe say very briefly about your work and expertise, and note if you have any updates to the conflict of interest declaration that you've already made. And so in terms of order, I'm going to kind of go through the order of the Zoom room that I see. So I'll start with Dr. Stephanie Nichols.
Thank you. Good morning, everyone. My name is Dr. Stephanie Nichols. I am an associate professor at the University of New England School of Pharmacy located in Portland, Maine. And I also have an adjunct assistant clinical professor position at the Tufts University in the Department of Psychiatry. I am a board certified psychiatric pharmacist and excited to be here.
Thank you. Thank you for being here. Next is Dr. Martha Gold.
Good morning. I'm Dr. Martha Gold. I'm a physician. I am professor emerita at the CUNY School of Medicine and a senior research scholar at the New York Academy of Medicine. And my background is in medicine and public health and in cost effectiveness analysis and public deliberation. Happy to be here.
Great. Next is Dr. Rab Asseltine.
Morning, I'm Rob Asseltine, professor and chair of the Department of Behavioral Sciences and Community Health at UConn Health, and also director of the Center for Population Health there. I'm a mental health researcher with a concentration in suicide prevention.
Great. Next is Megan Golden.
Hi, I'm Megan Golden, and I'm a lawyer by training, but I'm co-founder and CEO of a nonprofit patient research and advocacy organization called Mission Cure, and we are focused on pancreatitis.
Wonderful. Next is Don Kreese.
Good morning, everybody. Before I forget, let me remember to say I have no updates to my conflict of interest disclosure. I'm an attorney who serves as my state's public utility ratepayer advocate here in New Hampshire. But I'm here today because I successfully raised an awesome 22-year-old daughter, despite the fact that she has, or maybe because of the fact that she has cystic fibrosis. And so my expertise is really that of a patient and family advocate.
Thank you. We're so happy to have you here. Next is Dr. Jason Schwartz.
Hi, good morning. I'm Jason Schwartz. I'm an associate professor in the Department of Health Policy and Management at the Yale School of Public Health. My research looks at issues in pharmaceutical and vaccine regulation, policy, and policy making, and no further conflicts.
Dr. Brian O'Sullivan.
Good morning. I'm a pediatric pulmonologist and professor of pediatrics at the Geisel School of Medicine at Dartmouth, with a background in medical ethics and a particular interest in the cost effectiveness of medications for Don's child with cystic fibrosis.
Wonderful. Next is Dr. Tara Lavelle.
Hi, everyone. I'm assistant professor at Tufts Medical Center and a health economist. And a lot of my work is focused on the cost effectiveness and value of new medications and new interventions. And so my work is focused on mental health. I also have family members with serious mental illness, and so I bring that perspective to the conversation as well.
Thank you. Dr. Jean Ryer.
Morning, everybody. Jean Ryer, I'm director of the New Hampshire Citizens Health Initiative, which is a multi-stakeholder convener to improve health and healthcare in New Hampshire. I also lead the work on delivery system and payment reform at the University of New Hampshire Institute for Health Policy and Practice, and I have no further conflicts. I have no conflicts of interest, actually. So thank you.
Thank you. Dr. Steve Kogut.
Morning, everybody. I am Steve Kogut. I am a professor at the University of Rhode Island College of Pharmacy in the Department of Pharmacy Practice and Clinical Research. My areas of specialty are pharmacoeconomics and managed care pharmacy, and I teach and conduct research in those areas. I have no updates to my conflicts of interest to report.
Thank you. Next on the Zoom screen is from CEPAC is, I'm actually not seeing, did I get everyone there? Oh, no. Rebecca Kirsch, sorry. You're just below my screen, sorry.
Sure. I am Rebecca Kirch, based in Washington, D.C. with the National Patient Advocate Foundation. My background is in health policy, but I also am a caregiver of a son with a mental illness. So I bring several perspectives, including expertise by experience. Glad to be here today.
Thank you. We're glad to have you. And I just thank all of my colleagues on the CEPAC. I think we're going to have a really broad range of expertise to evaluate the ICER report findings today. And I'm very happy for that. So at this point, we'd like to call on individual patient and clinical experts to introduce themselves. And please remember to declare any potential conflicts of interest that would be relevant to this conversation. So I'd like to start with Dr. Nagendra.
Hi, everyone. My name is Dr. Arun Nagendra. I'm a clinical psychologist and the Director of Research and Scientific Affairs at the Schizophrenia and Psychosis Action Alliance. We are a nonprofit patient advocacy organization. Our mission is to dismantle barriers to access and promote recovery for the millions of individuals affected by schizophrenia and related conditions through research, education, service, and advocacy initiatives. I have no personal conflicts of interest, and I do not have any updates to my conflict of interest disclosure for our organization.
Thank you. And that information appears on the screen for the audience. Thank you for joining us. We're looking forward to your expertise. Mark Pomper.
Yes, hi, my name is Mark Pomper. By way of introduction, I'm the parent of a 31-year-old young man who suffers from schizophrenia spectrum disorders. I'm a recent retiree, having spent 35 plus years in Wall Street in different capacities, in investment banking, prop trading, and corporate bond analysis, working for JP Morgan, Goldman Sachs, Lehman Brothers, and most recently the Munich Re companies. I'm married with 3 children, and my wife, Raina, regularly volunteers for the National Alliance on Mental Illness. It goes by NAMI, where she hosts calls for other caregivers who are trying to work through serious mental illness.
Thank you for joining us. We're looking forward to your comments and your expertise. Dr. Steve Lamberti.
Good morning, everybody. I have no conflicts of interest to disclose. I'm a professor of psychiatry here at the University of Rochester Medical Center, where I serve as academic chief of the community division and chair of the Research Subject Review Board for Behavioral and Social Sciences. All of my clinical research and teaching efforts have been aimed at helping people with schizophrenia and their families and schizophrenia spectrum disorders. Thanks.
Thank you. Thank you for joining us. Dr. Vinod Sarari.
Hi, everyone. I'm a psychiatrist. I work at a community mental health center in New Haven, which is a collaboration between the State Department of Mental Health and Yale's Department of Psychiatry, where I'm also a professor. And I direct a program for specialized treatment early in psychosis that does a variety of research projects, clinical and services, and also some translational work and workforce development around the care of individuals who are early in the course of a schizophrenia spectrum illness. And I don't have any updates for my conflict statement.
Thank you. Thank you all for joining us. I think we have an amazing, diverse range of expertise today. So I just would remind everybody as we get to the rest of the session that we would request that any other speakers, including policy roundtable participants and individuals making public comments, have to announce, if possible, if you would, any financial relationships with industry or any other potential influences on judgment when they speak, and we will also present this information that's been pre-registered on slides. So with that, It is a joy to introduce, for my first time introducing the new president of ICER, Sarah Emont.
Thank you so much, Jason. A pleasure to be with all of you today. As Jason said, I'm Sarah Emont. I am the new president and CEO of ICER. In case anyone is wondering, Steve is here. Dr. Steve Pearson will be joining us later on to moderate the policy roundtable. We are so thankful that he's continuing on in his role, in a role as special advisor for ICER. But it is my pleasure to be able to welcome everyone today to this very important discussion. When we decide on a new topic and think about what we're going to try to tackle from a comparative clinical effectiveness and comparative cost effectiveness perspective, we always want to start by thinking about why we are here. And when our team worked with the patient community, the schizophrenia patient community, we heard some important perspectives about what it was like to live with schizophrenia. And this quote stuck out to us, and we wanted to share it with you today. The first symptom I really noticed was the paranoia. That led to delusional thinking, and I started to hear a voice. Thought that the newscasters and radio announcers were talking to me personally and sending me messages through the television and through songs being played on the radio. That made it really difficult because I couldn't enjoy the things I wanted to do. I'm an artistic person, so I wasn't able to enjoy my life anymore. And over time, it progressively got worse. As we continue through our introduction today, we will all do our best to remember the lived experience that we have learned about through doing this report and that we will hear from today from the patients so that we understand that this is not just an academic exercise. This is an exercise that impacts real people. Next slide, please. Okay, thank you. And we like to also reflect on the timing. We are looking at a new therapy that we expect and hope will get FDA approval. And we are doing so and remembering that it's a bit of a celebration, right? What happens when a new treatment comes along for a serious condition? We are excited. We have hope, but we also have questions. Questions both as patients, caregivers, clinicians, and policymakers. How do I weigh the risks and the benefits of a new treatment? How does this fit into the existing treatment landscape? Is this first line? Is this second line? How will I think about this for my own treatment journey? And then importantly, we don't want to shy away from questions about the costs. How do we think about a reasonable price? One that's reasonable for patients, for the health system, for the government, in a way that is sustainable. And I am so proud of what we do at each of these meetings by ending with a policy conversation, because where do we go from here? What lessons can we learn from what we have studied over these past 8 months? What can we learn to improve the research paradigm for people living with schizophrenia, to improve how we do things like model mental illness? Those conversations and questions will be part of what we talk about today. Next slide. One of the reasons that it's important for ICER to center our conversation about costs is because there are real consequences that happen in a healthcare system that does not think about costs from the perspective of what is fair or what is reasonable. And we appreciate the stories that we have been able to collate over the years, and these here represent some excellent reporting from Kaiser Health News. We have the wards of Chicago, who, when their twin sons were born premature, incurred $80,000 in medical debt. We have the Bucks of Arizona, who tried to go see a doctor to help with a condition, but because they had an outstanding debt with that doctor, they were turned away and ended up in the emergency room. And we have the story of Sherry Foy, who needed to have surgery in an emergent basis and ended up going into bankruptcy in order to pay for that surgery. And just this week, we learned that the state of Delaware is raising the health insurance premiums it charges for these state employees by 27%. And while they try to put it in context of, well, we've given a wage increase of over 30% over the last 7 years, so hopefully this isn't too much of a burden, I was reminded when reading some coverage from STAT that It's not supposed to be that all of our wage increases go only to healthcare. We have other things that we want to pay for as individuals and families. And the Delaware news came with the 3 top drivers of that increase in insurance premiums were hospital costs, outpatient hospital costs, specialty drugs, and emergency room visits. So on to the next slide, we want to make sure we understand why it's important to think about other people in the healthcare system. And that's because we have the people in the room with their doctor trying to make a decision about a treatment option in front of them. And the cost associated with that for them personally is also very important. But there are other people in the healthcare system that are impacted by the decisions we make about pricing and access. And it's imperative upon all of us to remember that as we do this work. Okay, just a few more slides before we get into it today. On the next slide, just for those who aren't familiar, Institute for Clinical and Economic Review, that's us. We are the convening organization for today's meeting of the New England Comparative Effectiveness Public Advisory Council. You had a chance to meet them at the top of the hour. They are a distinguished group of health economists, methodologists, practicing clinicians, and patient and public representatives, and we're so grateful for their participation today. Next slide. We believe in being very transparent about our funding. Not only can you see the percentages of the support that goes to our work here on this slide, you can visit our website to see a list of every organization that has given us money over the last 12 months. I will emphasize that the money that we do receive from manufacturers, health plans, provider groups, and pharmacy benefit managers is only to support our annual policy summit and related activities and does not support our research. Next slide. So a little bit about how the report was developed. I mentioned it's about an 8 or 9 month process. It involves developing a research scope with input from patients and patient groups, clinical experts, manufacturers, and other stakeholders. We have an internal evidence analysis that was conducted and led by Jeff Tice, who will be taking over in just a moment from the UCSF, and modeling done by Mel Whittington from Tufts Medical Center. All of our work goes up for public comment. We review and respond to all of the public comment. For those interested, those responses are also available on our website. We are deeply grateful for the expert review that we received from Dr. Abhidargam, Dr. Davies, Dr. Martyr, and Dr. Nagendra, with the caveat that none of them should be held as endorsing any part of our report. Their expert review was incredibly important in improving the quality of our report, and we thank them again for that. Our evidence report, which many of you can find on the website if you sort of want to follow along today, has several different sections that all support the voting that will take place today with the New England CEPAC. And they will be talking about the comparative clinical effectiveness. They'll be talking about the patient and caregiver perspectives and the other benefits and contextual considerations. And they'll be talking about the long-term value for money. Next slide. When we think about our value assessment framework, for those who aren't familiar, this is the document that is sort of the guide stone for how we do our work. We just want to highlight here that the report is reflecting all of these buckets, and all of these buckets are an important part of the conversation today. We'll have weighing evidence, which you can usually see in the green buckets. How much longer do you live? If it's a life-limiting condition, how much better do you feel when you are on the treatment compared to a comparator, and how much are we spending and saving with the potential new treatment? And the part in the blue box is just as important and sometimes difficult to quantify. And that's why we are so grateful to have a patient advocacy organization, a caregiver, and clinical experts with us today to help us remember the special and ethical priorities that might arise when we think about a new treatment. Is there a societal reason that we might want to emphasize and encourage the adoption and perhaps even the payment of particular treatments? And do we want to think about what benefits beyond health that are sometimes difficult to measure are still important when we do this really difficult sometimes work of adjudicating the comparative effectiveness of a new treatment? Next slide. My pleasure to end with just a quick overview of our agenda today. We'll be moving on to the presentation of the clinical evidence next with Dr. Tice. Dr. Whittington will walk us through the economic model. We'll have some public comment and discussion before our lunch break. The CPAC will then come back, deliberate on the evidence, and vote. And after another break, Dr. Pearson will take us through an engaging policy roundtable discussion where we will try to tackle some of the open policy questions about what we do with the evidence now that we have deliberated it. And we should adjourn by 4 p.m. Eastern today. With that, it is my distinct pleasure to introduce Dr. Jeff Tice from UCSF to walk us through the comparative clinical effectiveness.
Thanks so much, Madam President, and thanks to everybody for joining us today. Next slide, please. I just wanted to acknowledge my key collaborators, all our ICER staffers who really did the heavy lifting of the evidence review and synthesis. None of us have any disclosures to report other than my institution, UCSF, it has a contract with ICER to do this work. Next slide, please. So everyone's very familiar with this, but I just wanted to set the groundwork with some background on schizophrenia. It's a serious mental illness that affects how a person thinks, feels, and acts, and of course, affects those around them. It affects almost 4 million individuals in the United States and 24 million people worldwide. Interestingly, Black Americans are diagnosed at about twice the rate of white Americans based on population. And even within the population of patients living with schizophrenia who are diagnosed, Black Americans do worse than white Americans or other Americans living with schizophrenia. And the economic burden is enormous, 343 billion, excuse me, in a recent estimate, with the vast majority of that being societal costs, not direct medical costs. Next slide, please. Patients living with schizophrenia, their symptoms are often grouped into 3 broad categories. The first is positive symptoms. These are the ones we typically think of with schizophrenia: the delusions, the hallucinations, the disorganized speech and thought and behavior. But patients tell us that they really suffer from the negative symptoms: poor motivation, lack of enjoyment of life, lack of social interaction, and the cognitive issues, impaired executive function, attention, and memory. And really, our therapies to date only address positive symptoms, and in some ways can make negative symptoms and cognitive symptoms worse. Next slide, please. In talking to people living with schizophrenia, we heard 3 broad categories of the impact of the disease on their life. First, it's not just the day-to-day tasks of life are challenging. They have a hard time keeping a job, staying in school, maintaining relationships. And this leads to isolation, loneliness, and they really feel the stigma that society places on patients living with schizophrenia. There are also a number of challenges with current medications. It takes a long time to find a therapy that works for them, that balances the benefits and the side effects. And even the best cases, the symptoms are not all well managed, and there are often side effects that they have to live with. So they have a lot of hope for new therapies, those with fewer complications, with less emotional suppression, so less exacerbation of the negative symptoms. And ideally, all 3 of the symptom classes are improved with the new medications. So that's what patients and their caregivers hope for. Next slide, please. So there are a number of treatment options that are currently available. They're so-called first-generation antipsychotics, which often were burdened with movement disorders as side effects. Second-generation antipsychotics, which were burdened with weight gain and the long-term health complications of significant weight gain. There are a number of long-acting injectable forms of both the first and second generation antipsychotics, which have been a real step forward in terms of adherence to therapy and control of symptoms. We're not really going to consider them today because the therapy under consideration currently only is available in an oral form. But I did want to emphasize that there are a number of non-pharmacological interventions that are really important in the complete care of a patient living with schizophrenia. There are a number of cognitive behavioral therapies, cognitive remediation therapies, social skills training, interactive and social group therapy, and a number of other interventions that I highlight here. We're not going to talk about them today, but all patients living with schizophrenia really need both pharmacologic and non-pharmacologic support to optimally manage their illness. Next slide, please. So KarXT is a therapy of interest today. It's really a combination of 2 therapies. xanomeline, which is a muscarinic agonist, particularly targeting the M1 and M4 receptors, and was initially developed for improving cognition in patients with dementia. So there's actually hope that this will turn out to have benefits in the cognitive domains for patients living with schizophrenia. And it's a novel mechanism of action. All the current drugs focus on antagonizing the dopamine receptors, so particularly the D2 receptor. However, muscarinic agonists have a lot of side effects. And so there's an additional drug added, trospium, which really is there to prevent the peripheral side effects of muscarinic agonists. And so the combination is KarXT. You see the text below. I've already spoken to that. Next slide, please. So today we're going to focus on the comparative clinical effectiveness of KarXT. The comparators that we picked were aripiprazole, in part because it has a lesser side effect profile than many of the other medications used to help with the symptoms of schizophrenia, and then olanzapine and risperidone, which are two of the more effective therapies, but they have more side effects. For the acute phase, when patients are hospitalized or are treated for acute worsening of psychotic symptoms, we did our own systematic review and network meta-analysis of all 4 therapies. For the maintenance phase, there are no data available for KarXT yet, and we just relied on prior published systematic reviews and network meta-analyses of the 3 drugs listed above. Next slide, please. So now I'll turn to the actual clinical evidence. There are 3 clinical trials of KarXT, Emergent 1, 2, and 3. All 3 use the same design. They're patients who are hospitalized for acute symptoms. They're followed for 5 weeks during that inpatient hospitalization. And here are their baseline characteristics. The mean age is about 44 years. I will note that most patients with schizophrenia are diagnosed in their late teen, early 20s. So these patients have been living with their disease and have received treatment for schizophrenia over a 20-year period. So this is not a treatment-naive population. 75% of the patients are male, and interestingly, a little less than 75%, but when you look at the US site, 75% are Black Americans. So overrepresented in part, again, reflecting the epidemiology where Black Americans are more affected with schizophrenia, and also likely the fact that they're not well managed and so have more acute exacerbations. So when we're looking at a hospitalized population, Black Americans may be overrepresented. Next slide, please. So for our network meta-analysis, we just talked about the population. We're focusing on a number of key outcomes. There's a standard symptom score that has been used for decades in schizophrenia. The PANS, or Positive and Negative Syndrome Scale score. And this is often dichotomized into a response, and the cut point that's commonly used is 30% improvement from baseline, though a number of others are used in other studies. An important harm, as I mentioned before, with the second generation antipsychotics is weight gain, leading to metabolic syndrome, diabetes, and so on. And so we focused on that, and also all-cause discontinuation rates, which reflects both side effects, lack of efficacy, and patient acceptance. We didn't restrict trials to just 5 weeks, because a number of the earlier therapies were studied for durations between 3 and 8 weeks. And then we used a Bayesian random effects model for our network meta-analysis. Next slide, please. So here's an overview of the network. There are 33 different randomized trials included. The lines represent direct comparisons between the different therapies of interest, and the thickness of the line represents the number of trials. This varies a little bit for different outcomes. Not all trials reported all of the outcomes of interest. Next slide, please. So here are the results. I'm going to take a little bit more time to orient you, because we'll have a couple of slides with tables like this. And you're probably going to mainly want to focus on the first column. That's the comparative effectiveness of KarXT versus the other therapies. So a box, I'll pick the first box in the upper left that has a number in it, 1.48. That's the estimate of the difference in the PANSS response, the relative risk for a PANSS response for KarXT versus aripiprazole. So the top of the column compared to the right side of the row, that gives you the comparison of interest. And then for all of the tables on the subsequent slides as well, if the box is white, unshaded, that means that the estimate, the 95%, the 95% credible interval for that estimate includes 1, which means there's the potential for no difference between the estimate suggests no clinical difference between the two therapies. So here you see all the comparisons of KarXT versus aripiprazole, olanzapine, and risperidone. The boxes are white, so there's not a significant difference. The credible interval includes 1, but compared to placebo, there's a 2-fold increased response rate by the PANSS score. So no difference between KarXT and the other therapies in the comparative effectiveness, but clear difference with placebo. Next slide, please. So we also looked at weight gain, and these are the absolute differences in kilograms. So in this case, the boxes are shaded white when the credible interval includes 0, no difference in weight. So you see no difference between KarXT and aripiprazole, but significantly less weight gain, 2 to 3 kilograms less when compared to olanzapine and risperidone, and then no difference compared to placebo. Next slide, please. For all-cause discontinuation rates, was a borderline significance, was not significant between KarXT and aripiprazole. This is a relative risk, and the trend was towards more discontinuations with KarXT than aripiprazole, but not significant. However, there were significantly more discontinuations with KarXT compared to olanzapine and risperidone. And again, this is in short week trials, 3 to 8 weeks, and then no difference compared to placebo. Next slide, please. There are a number of important harms that we focused on. As I said, the first generation antipsychotics often had movement disorders, extrapyramidal symptoms that then long-term led to more permanent movement disorders called tardive dyskinesia. There were nominally a few more patients who had extrapyramidal symptoms, akathisia, dyskinesia, dystonia with KarXT compared to placebo. No statistical comparison was reported for this. High levels of prolactin is sometimes a problem with some of the earlier antipsychotic therapies. This leads to breast enlargement and sometimes lactation, so a big problem. You see there a small increase in prolactin in the KarXT arm, a small decrease in the placebo arm. Again, no statistical comparisons were reported. And then for commonly reported adverse events, we see nausea, constipation, dyspepsia, and vomiting, all being more common with KarXT than placebo. These reflect either muscarinic activation in the periphery of the GI tract or anti-muscarinic effects. So some patients end up, even though we have a combination of both anti-muscarinic and muscarinic effects with the two drugs, some patients experience more muscarinic side effects, some more anti-muscarinic. Next slide, please. There are a number of controversies and uncertainties. I think the most important one is that these drugs are really not just going to be used in the acute setting. If somebody is successfully managed, they have good control of their symptoms during an acute setting, clearly they're going to continue on this therapy for the long term. And all we have are 5-week data for KarXT. So we really don't know what's going to happen in the long term with these therapies. Both benefits and harms. There may be harms that are benefits that are unexpected that we're going to see with long-term therapy. For instance, we may see cognitive improvements that haven't been demonstrated yet in the short-term trials. Symptom improvement, there's uncertainty, again, on both cognitive and negative symptoms long-term. And then generalizability, this was a subset of patients who have been treated for 20 years and now are experiencing an acute worsening of their symptoms. We don't know that that's clearly not representative of all patients living with schizophrenia, and we don't know whether there will be utility in other patients. And then again, at the U.S. sites, 75% of patients were Black Americans, and whether that can generalize to other patients living with schizophrenia, there's some uncertainty there. Next slide, please. So in the potential other benefits and contextual considerations, so these are things, as Sarah mentioned, go beyond the clinical and economic evidence. The new mechanism of action holds hope that this will offer a new therapy that will be useful for patients who haven't found benefit for the 20+ medicines that are currently approved for schizophrenia, and that this may also address other symptoms for patients who are managed reasonably well with current therapies, but suboptimally. There are, of course, major long-term health consequences of schizophrenia. There's a 10-fold higher risk of suicide in patients living with schizophrenia compared to the general population, and a markedly shorter life expectancy, about 15 years, in part because of the suicide, in part because of the side effects of the medications, and so on. And then, of course, as I've emphasized throughout, schizophrenia disproportionately affects the Black population, so we may be able to address some disparities in our society by more effectively treating schizophrenia. Next slide, please. We received a number of public comments. One was about the NMA. We included all available trials. There was some concern that earlier trials had larger effect sizes than later trials. So we did do a sensitivity analysis. I didn't present these data, but they're in the report and the supplement, excluding trials before 2008, and it didn't change our estimates appreciably or the conclusions of the clinical evidence review. We received a number of comments about taking the assessment of cognitive data in these short-term trials with a grain of salt, in part because when patients are acutely psychotic, so have lots and lots of positive symptoms, it also affects their cognitive function. We treat the voices, the hallucinations, the paranoia, and they often their cognitive function improves as well, and that may not be a direct effect on cognitive function. It really focuses on the positive symptoms. And then a common refrain, the report is premature because we really don't have any evidence on maintenance, which is really the potential value of this therapy. This is the nature of drug approval process in the US. We are timing our report to the likely FDA approval of this therapy, and that's when decisions around value are made and when decisions around pricing are made. So it's a suboptimal, but that's the system we have in the US, and we think we have our biggest impact by having our public process now. Next slide, please. So in summary, for the symptom scales, KarXT was significantly better than placebo, but there were no significant differences between KarXT and the 3 comparators. For weight gain over 5 weeks, KarXT had significantly less weight gain than olanzapine and risperidone, but there were no differences between KarXT and aripiprazole or placebo. And then discontinuation rates with KarXT were significantly higher than those observed for olanzapine and risperidone, and they were numerically but not statistically higher than the other 2 therapies. Next slide, please. So putting that all together, comparing KarXT to no antipsychotic therapy, clearly had improvements in symptoms for patients, some additional side effects, but the real uncertainty comes from long-term follow-up. So we found this to be promising. It looks effective versus placebo in the short term. But when we're thinking about maintenance, again, our real focus, because we think the value of this therapy will be in long-term maintenance for patients living with schizophrenia, we think the uncertainties are high enough that we give it a promising but inconclusive rating. For KarXT versus aripiprazole, really no differences in efficacy, in weight changes, in discontinuation rates, So we don't know fully the long-term benefits. There's no clear signal that it's much better than aripiprazole in any of those domains. So we give this an I rating insufficient and look forward to longer-term follow-up data to make a more conclusive decision about that. The other important uncertainty is that the only evidence we have is indirect. So we don't have any direct head-to-head therapies. We're looking at aripiprazole versus placebo, KarXT versus placebo, and then making some judgment about the relative efficacy of the two, one versus the other, but we don't have any direct evidence, so that adds to the uncertainty. For KarXT versus both olanzapine and risperidone, no differences in efficacy, but clearly less weight gain over a 5-week period, so that's promising. But we really don't know how that's going to play out in the long term, whether that will turn into less metabolic syndrome, less diabetes, less strokes and heart attacks, and so on. So again, indirect evidence, some evidence suggesting benefits of KarXT versus these two agents, but lots of uncertainty. So we gave a promising but inconclusive rating to both of these comparisons. Next slide, please. And with that, I'm happy to take questions.
Thank you, Dr. Tice, for the presentation and for the enormous amount of work that went into this report. Congratulations to you and to the ICER research team. I'm just going to start the questions myself, actually, by sort of pushing a little bit, pushing on some of these things that you've sort of, you've delved into a little bit around external validity, which is commonly a problem in clinical trials. That, as you've referenced, this is patients that were or individuals living with schizophrenia that had acute exacerbations and ended up in a hospital and then got switched. So that is one external validity issue that you've referenced. I mean, how do you think that, and I guess I would also, without knowing much about just given the nature of the disease condition, I would speculate that there's issues around enrollment and recruitment into clinical trials. I would speculate, I don't know much about this, that many patients approached about inclusion in trials decline involvement. Have you had any sense for whether that occurred or not? And if so, do we have any reason to doubt the validity of these trial results into a larger population?
Challenging question, and I might let some of the clinical experts address that to some extent. I will say contextually, this is the way all the other antipsychotics were approved, and in general, they were found to be effective in the maintenance phase, even though they were initially approved for acute exacerbations. The same issues with the enrollment of patients with acute symptoms and electing to potentially be randomized to a placebo when you're acutely ill is challenging. So I'm sure there are, it's definitely not a typical individual who agrees to participate or in concert with their caregivers and decision makers agree to participate in these trials. But I might open it up to the clinical experts to give a little more perspective since I've not actually enrolled patients in trials like this.
Thank you, Dr. Tice. I think Dr. Ferrari's, there's a couple questions to CEPAC that I'm going to get to in a moment. Dr. Ferrari has his hand up too. Were you responding to that, or did you have a question?
Oh, I'm happy to respond to it, but am I allowed to ask questions here, or should I wait?
Yeah, why don't you do both, and then we'll pivot to the CEPAC members who have questions. That sounds perfect.
Great. No, I mean, I think in response to Jeff, I think that's right, that this looks like standard operating procedure for approvals of antipsychotics to study mostly chronic samples with recent exacerbations and symptoms to demonstrate that they beat placebo. So in that respect, I think it's sort of meeting the standard that other initial antipsychotics met. I guess my question was really about, given that this is a structural issue in the way we approve drugs in the US, that they pass a placebo in a mostly sort of not representative sample. So we don't have actual comparative data head-to-head between this and other antipsychotics. I'm just curious about, given that this is a common issue with many drugs, it's in terms of valuing the drug, we don't have a way to relatively value it against other medications directly. But we also don't have a way to evaluate its place in treatment because it's likely to also be used as an adjunctive medication initially, given that its mechanism of action is distinct from the current medication. So it may actually work as a supplement. So I guess my question is, how would one evaluate its promise in terms of novel use, given that none of those have actually been tried yet in terms of valuing it compared to what will be many cheaper alternatives that we already know work quite well. And I'll add, I think maybe a response is the heterogeneity amongst even samples that look clinically similar, as in same age, same severity of symptoms, is significantly more in the younger group than in the older group. And so I think this raises the question of external validity, is if it works in a middle-aged sample to some degree, it's much harder to extrapolate that to a younger group, both in terms of efficacy and side effects, because there is variation. It tends to be that the older drugs work a lot better in the younger population, but they also cause more severe extrapyramidal side effects for the same dose. So, you know, there's another sort of phase of illness kind of question too. I'll stop.
All right, thanks. Yeah, challenging. I think some of this hopefully will be addressed actually in more detail in the policy roundtable. You know, certainly one of the things we try and do with our process is signal when the standard FDA approach to approval has weaknesses, and maybe advocate for changing the way the FDA sets up their goalposts for approval. They do change over time. And I think, yes, we certainly have heard from some clinicians that they want to potentially use this as first-line therapy because, you know, it potentially has fewer side effects. We may be able to improve adherence from the get-go and thus really impact the long-term trajectory of patients' lives who wrestle with this. But we have no data yet. And I think that's going to be a question that comes up during the policy roundtable. Should we be using this earlier? Should we be is this data adequate to extend the use of this drug to adolescents who weren't included? Can we generalize to patients over 65? Body composition changes, the side effect profile changes. You know, the clinical trials had an upper limit of age 65. Should we allow 70-year-olds living with schizophrenia who are failing current therapies to use this? Those are the kind of things that really belong in the policy roundtable because we don't have evidence. You know, we do the best we can, again, using standard statistical techniques, the network meta-analyses, but they are fraught with problems, and we would really prefer to have direct randomized trial evidence with active comparators, but we're limited. We do the best we can, and we try and model the long-term benefits and harms of both when looking at the economic side of things that Dr. Whittington will present later. So hopefully I somewhat addressed your question. I know I kicked the can down to the policy roundtable, but those are important issues. I think that's not directly relevant to the evidence before us, but go beyond the evidence, and that's really the purview of the afternoon session.
And I'm sure will come up in that context. So we're aiming for about 9 minutes until we transition to the economic modeling, and I see 5 hands up. So I think we might be able to attempt here. Maybe I see Don, then Brian, Megan, Steve, and Stephanie. Do you want Don? Anyone ahead?
Sure. I have a quick question. I think that one of the clinical experts might be able to dispatch rather effectively. I'm used to diseases where outcomes can be measured with a lot of precision, but here we have a disease that has a wide variety of effects. Many of them are subjective. And so I'm wondering how universally accepted the positive and negative syndrome scale truly is. Is it the consensus view of everybody in the schizophrenia community that that is the right way to measure the outcomes of this disease, or is there any pushback? The evidence summary says that the validity is accepted. I just want to push back and make sure that that is in fact true.
Jeff, I don't know if you want to take that, or do you want to like Mark Pomper or someone like that?
I was going to let the experts, I mean,
Okay.
there are other things that are used. There's a clinical global improvement scale, which is more the clinician's gestalt. You know, there have been cross analyses between these, but I think the PANS is the standard and pretty well accepted. But I'll let the experts hopefully give a brief response as well.
Yeah, the PANS is good at doing what it does, which is measuring positive and negative symptoms, but there are multiple symptom dimensions and other tools to measure those symptom dimensions, like the matrix or the OOPSA for cognitive impairment. And there are functional assessment scales as well. So that's part of the challenge, is knowing where to look, because this group of diseases has multiple symptom dimensions.
Thank you so much.
If I could chime in just
Oh yeah, please.
in terms of communication with our son, it's not as though we go into a hospital and say, oh, his PANS have gone up or down. It's not part of the kind of regular discussion with clinicians at all.
No, that context is helpful. Thank you. I think Brian's next. Dr. O'Sullivan.
Yeah, and I think Dr. Sahari and Jeff may have already answered my question. I was just struck by the onset of the disease between, say, 16 and 24 years, but everyone in the study the average age was 44. So I was wondering, Jeff, if there was any, and I hate post hoc subgroup analysis is not worth very much, but were there any looks at younger patients to see the value of this, maybe early use and obviating the need for hospitalizations and chronic stuff if this really works well? I wasn't sure if there's any evidence to help us there, but you've already answered that, I think.
Yeah, I mean, I will say, you know, they excluded patients who had never been treated before. So it really hasn't been looked at in that context yet. I'll have to go back and look and see whether they did subgroup analyses by age. I'm not remembering there being any important difference if they did look at that.
Presumably, even if they did questions about statistical power to see differences. I think Megan's Megan Golden.
Yes. Quick question from a non-clinician scientist. Speaking of statistical power, am I reading it right that on pretty much all of the dimensions except discontinuation and negative score, that CAR-XT was superior to aripiprazole, but not statistically significant?
It had higher discontinuation rates than aripiprazole, but yes, the trend was towards benefit. I'll have to go look back at the table, but that's my recollection for everything except for discontinuation rates. The trend was towards improvement compared with aripiprazole.
Thank you. We can also confirm that offline as well. Steve, I thank you for graciously offering to stand down, but I think we actually have time to get to both you and Stephanie.
Terrific, thanks. And thanks for that great summary of the evidence report. As I was digging into the data, I was maybe surprised or a little disappointed to see that for a majority of patients, these medications don't achieve the PANS response that the outcomes set. I think it was about 40% in Emergent 3. And as I calculated a number needed to treat to benefit, sort of back of the napkin, it works out to be about 6, which doesn't really blow you away. But on the other hand, it seems like that's ballpark for all of the comparators as well. So I think one thing that maybe doesn't come through in the report is just that on the efficacy side for these medications, there still are a lot of patients that don't seem to benefit. And just wonder if there's a comment that you could make to help frame my thinking around that.
No, I mean, I think that's exactly right. That's true for any of the therapies. But I think the hope is that, maybe there are different flavors of schizophrenia that we aren't able to tease out yet. I will say there haven't been any pharmacoeconomic, what do I want to say, genetic analyses or other things to try and identify, oh, this population is more likely to respond to olanzapine, or this population is more likely to respond to trilifon or to CAR-XT yet. I mean, I think the hope is with a new mechanism of action that this may help a subset of patients that didn't respond well to other therapies, but that it's still early days in that. It's clearly not a panacea for this illness, unfortunately.
Thank you. I think Mark Pomper, do you have a question or a comment?
Maybe just a little bit of both. I just wonder, as you kind of go through the medications, obviously you know a whole lot more than I ever will, but clozapine seems to be a kind of old school med that does seem to have some real effectiveness, and I wondered why if it might be included in future studies as a benchmark.
Yeah, the reason it wasn't included was it's typically used for treatment-resistant patients with treatment-resistant schizophrenia, and they were excluded from this trial. So that's really a comparator later on. I mean, we certainly hear from patient communities and clinicians that that it isn't used as much as it should be, but as you know, it has really potentially rare but life-threatening adverse effects. And but anyway, the main reason it wasn't considered here in the modeling, it is sort of the pathway of therapies leads to clozapine in the modeling, but for the clinical analyses, patients who would be eligible for clozapine were excluded from the clinical trials.
Thanks very much.
Thank you both. Dr. Nichols, Stephanie Nichols, do you have a question, I think? Thanks for being patient.
I do, of course, and I'm just going to jump real quick on clozapine as well. I think part of that too, thinking about maybe a round table and just thinking about regulatory issues, is that the REMS associated with clozapine and the blood draws for life are a major barrier. And so that's one reason why we underutilize that in this country. What my thoughts are about is the anticholinergic effects and the heterogeneity. I'm struck that trospium is crosses the blood-brain barrier and then it's effluxed back out by P-glycoprotein, and that might be part of where this heterogeneity is coming from. We know a lot of drugs inhibit P-glycoprotein, so there are definitely going to be situations where trospium is going to be available in the brain, and that, of course, is going to negate any of the muscarinic agonist effects of the drug. My other concern or thought about this is related to bowel obstruction, which is something we definitely see with clozapine. There were new warnings a few years back that came out regarding that. And it's something I think about with this drug, with the anticholinergic effects. And then finally, if this is going to be used in some people as adjunctive therapy, I'm presuming that's adjunctive to dopamine antagonists and maybe ones that cause metabolic dysfunction. And so those patients may very well be prescribed GLP-1 agonists, and we know constipation and, I would be concerned about risk of additive constipation and bowel obstruction when combined with this. So that's not to say that this shouldn't be an option that is used, but it's definitely something that I'm thinking about as well. Also opioids, but I think that would be less of a concern than maybe the GLP-1 agonists here.
Thank you for that context. So certainly, to address your second point, the patients with at high risk or who had, for instance, urinary obstruction or slowed GI transit were excluded from the trial. It was part of the exclusion criteria for all three trials. So, but a real concern and something we need to, that's going to need to be on the clinician's minds, partly why, again, this is probably more for the clinical, for the policy roundtable, but we need to be thoughtful about who's prescribing these initially. We think probably people who are real experts in the side effects and management potentially of those side effects may be appropriate in the early stages rather than primary care physicians, at least starting off. Well, thanks. I think we should probably turn it over to Dr. Whittington for the economic analyses now.
Yes, just on time. I'd like to introduce Dr. Mel Whittington. She is a senior fellow at the Center for Evaluation of Value and Risk in Health, a CEPAC at Tufts Medical Center. And we're delighted to have her here to present the economic analysis.
Thank you, Dr. Wasfi, and thank you all for being here today. Next slide. I want to first acknowledge Dr. Marina Richardson from ICER for her contributions to this portion of the assessment. We have no conflicts to disclose. Next slide. All right, the objective of this portion of the assessment is to estimate the lifetime cost effectiveness of KarXT compared to current standard of care that includes second-generation antipsychotics for the treatment of schizophrenia. Now, it's important to keep this objective in mind when appraising the methods and interpreting the findings that I'll talk through next. Our objective is not to estimate the most cost-effective sequence of treatments. We understand that with schizophrenia, treatment discontinuation and switching is common, and you will see how we will account for that on the next slide. But our objective is not to suggest the most cost-effective sequence, but rather our objective is to isolate the costs and consequences specific to KarXT to estimate the cost effectiveness of KarXT. Relatedly, our objective is not to model the reality of an individual patient's life, but rather we're trying to determine what a drug is worth for a population based on average effects, not individual effects or experiences. And finally, we know schizophrenia is a devastating disease with tremendous societal level consequences. And I'm so grateful we have patient and caregiver experts here to inform that part of the conversation. However, our objective of this portion of the assessment is not to develop a disease level model that comprehensively assesses the societal impact of schizophrenia. Rather, our objective is to estimate the cost effectiveness of KarXT. And thus we only model things that KarXT is expected to have a differential impact on as compared to second generation antipsychotics. Next slide. So with that, the intervention we modeled is KarXT, and we compared that to aripiprazole, which we believed to was believed to have the fewest side effects among the second generation antipsychotics. Now we are modeling a lifetime time horizon to be able to capture the potential long-term benefits of KarXT reducing metabolic syndrome and its lifetime consequences. And it is common for patients to discontinue and switch treatments over their lifetime. So this lifetime time horizon does require treatment switches to be modeled, but to achieve our intended objective, again, of isolating those costs and consequences of KarXT, the treatment switches were the same across both arms of the economic model because we didn't want the treatment switch to be primarily driving the results here. We wanted the costs and consequences of KarXT to be a primary driver. And so again, we aren't trying to model a real world patient experience, but to keep those treatment switches consistent between the intervention and comparator to isolate those effects of KarXT. So upon discontinuation of either KarXT or aripiprazole, depending on what arm of the model members of the model cohort were in, they switched to a second treatment basket that had costs and consequences characteristic of risperidone and olanzapine, which are widely used and represent a range of effectiveness and side effect profiles for second generation antipsychotics. Upon discontinuation of the second treatment basket, members of the model cohort moved to a third treatment basket that now has clozapine added in addition to risperidone and olanzapine. Clozapine was included in this third treatment basket in alignment with evidence and clinical guidelines suggesting clozapine can be an appropriate treatment for individuals who have discontinued at least 2 antipsychotics. Next slide. So to achieve our objective, we created a decision analytic model with an upfront decision tree followed by a Markov model. I'll show the structures of those in the upcoming slides. We had the United States setting with 2 different perspectives, healthcare sector perspective that informed our base case, and we present findings from the modified societal perspective as a scenario analysis. Our time horizon was of a lifetime, again, to be able to capture those lifetime potential benefits of reducing metabolic syndrome. All future costs and outcomes were discounted at 3% per year with a cycle length of 3 months. Our primary outcomes included costs, life years, quality adjusted life years, equal value life years, and years with diabetes. Next slide. This slide reports the model schematic for our acute phase, that upfront decision tree that was part of our decision analytic model. All members of the modeled cohort started in the acute phase of the model, experiencing an inpatient acute psychosis event in alignment with the clinical evidence for KarXT. And then the upfront decision tree assessed for clinical response, with adequate clinical response defined as a 30% improvement in the PAN score. So when an individual started the model, they were on the first treatment, whether that was KarXT or aripiprazole. Response was assessed. If it was not adequate, they switched to the second treatment and then on to the third treatment. Next slide. This slide reports our model schematic for the maintenance phase. So from the acute phase of the model, the upfront decision tree, members of the cohort transitioned to the maintenance phase of the model on the treatment that they were on at the end of the acute phase, whether that was the first, second, or third treatment. Now, the maintenance phase was a lifetime Markov model, and it tracked treatment switches. You can see that by the ovals here, the first treatment, second treatment, third treatment. It tracked treatment stopping. You see a state for off treatment. And then within those alive health states, it tracked relapses and treatment emergent adverse events. There's also a health state for death. Now, treatment emergent adverse events that were tracked included metabolic syndrome, diabetes, and cardiovascular disease, all of which were considered as irreversible. And then death could be due to all-cause mortality or mortality specific to schizophrenia, diabetes, or cardiovascular disease. Next slide. There are a few key model assumptions that are very important to consider when interpreting the results. The first of which is that we assumed KarXT was not associated with a risk of developing metabolic syndrome beyond that of the general population. And I'll speak more to this in upcoming slides too, but there was no significant difference in weight gained between patients treated with KarXT and patients treated with placebo reported in the KarXT clinical trials. Therefore, we assumed the same risk of metabolic syndrome as the general population. The second bullet, we assumed that there were no metabolic syndrome, diabetes, or cardiovascular disease at baseline. So that cohort that started our model, we assumed they were free of metabolic syndrome, diabetes, or cardiovascular disease, and thus the entire population treated was eligible for the potential benefit of KarXT, not increasing the risk of metabolic syndrome or its long-term consequences. And the final bullet on this slide, we assumed individuals in the cohort were on a treatment over the lifetime time horizon, except for a small proportion that stopped treatment at 20 years. Schizophrenia does require lifelong treatment, but some studies have shown a portion of the population stop treatment altogether. So again, when I show you the discontinuation numbers, you'll see discontinuation was high, but patients stayed on a subsequent treatment over their lifetime. Next slide. This slide reports the clinical response data used in the acute phase, that upfront decision tree. These values are from ICER's network meta-analysis on the 5-week probability of 30% improvement in PANSS that Dr. Tice recently walked us through. Now you'll see the numbers on this slide are different between the interventions, and that's because the relative risks from ICER's network meta-analysis were applied to a placebo probability of adequate clinical response. And it's worth noting that the relative risk point estimates as compared to placebo did vary between the interventions, and therefore it generated different adequate clinical response point estimates. But as Dr. Tice mentioned, and I'll bring up again on the next slide, adequate clinical response wasn't significantly different between the interventions on this table. Next slide. This slide reports the model inputs used for relapse in the maintenance phase. So in the maintenance phase, that Markov model that I showed, patients could experience a relapse based on the probabilities that are reported in this table. Now, in the maintenance phase, no evidence exists for KarXT in the maintenance phase, so we had to make an assumption here. Because KarXT was not significantly different from the second generation antipsychotics in terms of adequate clinical response in the acute phase, as evidenced by ICER's network meta-analysis, we assumed that KarXT's probability of relapse in the maintenance phase would be similar to that of the second generation antipsychotics. Thus, we assumed the midpoint between the range of second generation antipsychotics and varied this widely in sensitivity analyses. Next slide. This slide reports our inputs for metabolic syndrome. Again, there's no evidence of KarXT on developing metabolic syndrome. However, we assumed the same probability of that of the general population, which was supported from ICER's network meta-analysis of 5-week absolute weight gain data that we did have, and it wasn't significantly greater from placebo. Now, in the model, patients who do develop metabolic syndrome are at an increased risk of developing diabetes or cardiovascular disease. And then the model, of course, tracked those long-term consequences across the health outcomes. Next slide. Now, in the maintenance phase, individuals could discontinue treatment due to inefficacy, side effects, or their own decision. This table reports the 3-month probability of discontinuing for each of the interventions. Again, we don't have long-term discontinuation data for KarXT, so we used ICER's network meta-analysis on 5-week discontinuation. And so from that network meta-analysis, we took the relative risk of KarXT versus olanzapine, and then applied that to olanzapine's 3-month probability of discontinuation. Next slide. The model, of course, accounted for drug costs. For KarXT, a price is not yet known, and thus a placeholder price was used in the economic model of $20,000 per year based on an estimate from IPD Analytics. Please remember when looking at the results that this is purely a placeholder price, and please keep that in mind as I show results very soon. All of the other drugs that were included in the model have generic equivalents available, and thus the generic price is reflected in this table and what was used in the model. So you can see the prices for the second generation antipsychotics on this slide, ranging from around $40 per year for aripiprazole to around $1,400 a year for clozapine. Next slide. Now, in a scenario analysis, we did expand the perspective to a modified societal perspective. And again, our objective is to estimate the cost effectiveness of KarXT. And thus we model things that KarXT has a differential impact on as compared to the second generation antipsychotics. Societal level factors that KarXT is not expected to differentially impact were not modeled, as they would not influence the incremental cost effectiveness ratio. But considering that, this slide reports 3 societal level factors that could be differentially impacted by KarXT as compared to the second generation antipsychotics, including productivity losses associated with a relapse, as well as indirect costs for productivity for diabetes and cardiovascular disease, criminal justice costs tied to relapse, and then caregiver time spent caregiving. Next slide. All right, transitioning to the results. This slide reports our base case results, our model outcomes for KarXT as compared to aripiprazole. Please keep in mind that this assumes a KarXT placeholder price of $20,000 per year. So assuming that total costs were higher in the model pathway that started with KarXT, years with diabetes were fewer in the KarXT arm, and quality adjusted life years, and equal value life years were higher in the arm starting with KarXT as compared to aripiprazole. Next slide. So when we look at this incrementally, KarXT is associated with an incremental cost effectiveness ratio of around $163,000 per quality gained and $146,000 per equal value life year gained, assuming a KarXT placeholder price of $20,000 per year. Next slide. This slide reports our one-way sensitivity analysis. I love this figure. It can quickly show you which are the key inputs that are really driving the findings and where uncertainty in that input and how that impacts cost effectiveness. So from this figure, you can quickly tell that top input, that 3-month metabolic syndrome probability for KarXT, is a key driver of this model. And not making the assumption that KarXT is not associated with metabolic syndrome, cost effectiveness becomes far less favorable. Next slide. This slide reports a probabilistic sensitivity analysis showing the probability of KarXT being cost effective at certain thresholds, assuming a KarXT placeholder price of $20,000 per year. So at thresholds of $150,000 per quality and EVLY gained, there's about 34 to 40% of the iterations that fell beneath that threshold with that placeholder price of $20,000 per year. Next slide. We conducted numerous scenario analyses to test those key model inputs. The first row presents the incremental cost per equal value life year gain from our base case to serve as a reference when comparing the scenario analyses to that. Looking at the modified societal perspective row, cost effectiveness stayed nearly the same from the modified societal perspective due to the limited differential effects of KarXT compared with the second generation antipsychotic medications on those societal level factors that were included in the model. Now, this is not to suggest there isn't an enormous societal effect of schizophrenia. Rather, this suggests that as modeled, KarXT doesn't dramatically influence the net societal effects that are included in the modified societal perspective. The next row incorporates tardive dyskinesia. So if we make a more favorable assumption, like we did in this scenario analysis around tardive dyskinesia than what we did in the base case, and assume that while an adult with schizophrenia was treated with KarXT, they were at a 0% risk of developing tardive dyskinesia, cost effectiveness improves to around $67,000 per equal value life year gained, again, assuming a placeholder price of $20,000 per year. And then moving on to this bottom row, if we make a less favorable assumption around metabolic syndrome than what we did in the base case and assume a small risk of metabolic syndrome when on KarXT, the risk that was assigned in this scenario analysis was half of the risk of metabolic syndrome as aripiprazole, so still a benefit over the second generation antipsychotics, you see cost effectiveness worsens. So tardive dyskinesia and metabolic syndrome are kind of these two levers that have important implications for cost effectiveness. Next slide. We calculated health benefit price benchmarks for KarXT, and that health benefit price benchmark range was around $16,000 to $20,000 per year. Next slide. A few limitations I want to reiterate. This is not an estimate of the overall societal burden of schizophrenia. And so if you look at the model outcomes for the modified societal perspective, they can't be interpreted as an estimate of the overall societal burden and impact of schizophrenia. And secondly, there's no direct evidence for KarXT in the maintenance phase. And so we had to make numerous assumptions around the effectiveness of KarXT in the maintenance phase based on the short-term acute phase data that we do have. Next slide. We're grateful for the number of public comments we've received. I want to summarize a few here. Many public commenters were encouraging us to include tardive dyskinesia in the base case. We did not include tardive dyskinesia in the base case because there is no evidence for KarXT's effect on tardive dyskinesia, but also the trial evidence that we do have, KarXT was still associated with extrapyramidal symptoms. I think it was around 3.2% in the KarXT arm and around 1% in the placebo arm. So because extrapyramidal symptoms still occurred with KarXT treatment, there was no evidence to suggest that there would be a benefit of KarXT on tardive dyskinesia. But we do include it as a scenario analysis. Secondly, there are public comments to make the third treatment basket clozapine only. We didn't model clozapine specifically as the only drug that represented that third treatment basket, but rather a basket of treatments, and the basket has costs and consequences that are characteristic of the treatments within the basket. We did talk to clinical experts about this extensively, and we received feedback from the clinical experts that the 30% of that basket that we assumed was on clozapine was actually probably high as compared to what we see in the real world. And the last public comment here was that the societal perspective lacks breadth and depth. And again, our objective is not to assess the comprehensive societal burden of schizophrenia as a condition, but rather to isolate the costs and effects of KarXT, which is a potential treatment for schizophrenia. Next slide. And finally, before questions, just to conclude, assuming KarXT does not increase the risk of metabolic syndrome beyond that seen in the general population, treatment with KarXT resulted in less time with diabetes and in more quality-adjusted life years, and equal value life years. And at a placeholder price of $20,000 per year, the cost effectiveness is near the upper bounds of common thresholds, but it would be less favorable if it was associated with a risk of metabolic syndrome beyond that of the general population, and it could be more favorable if not associated with tardive dyskinesia. Next slide. Thank you.
Thank you, Dr. Whittington, for the very informative talk and for all the rigor that you and your team went into in preparation of this analysis and this report. So thank you. I will start by asking a question. I did note in your presentation that I was struck by the 3-month, the effect estimate that went into the model for transition state probabilities for transition into an exacerbation state for 3 months for no treatment was quite high. It was like, it's like almost a coin flip, right? So if you're not on treatment, that implies a sort of 50-50 almost, of, I think 41%. And can you just remind us, and I apologize if this was in Dr. Tice's presentation and I missed it, is that effect estimate derived from randomized data or from observational data? What I'm getting at is that I would imagine that if it were from observational data, that there's a different type of individual who would not be on treatment at all, so as to say that that might confuse treatment effects versus selection effects. I would be more reassured if this were from randomized data, and I don't know if you recall where that estimate came from.
Sure, let me speak a little bit more to that because that is an important point to bring up. I'm glad you're bringing it up. So what he's bringing it up is in the maintenance phase, relapse were tracked, and for no antipsychotic use, that model input used was 41%. I do not remember exactly the specific source that came from. However, I can tell you that the percent of the cohort on no antipsychotic is very, very small. So this isn't driving our findings here. The only way to get on no antipsychotic use in our economic model is at 20 years if you're part of that 18% that then discontinue onto no antipsychotic. So clinical team, others, I don't know if we want to add any more clinical color to that, but for the modeling purposes, it isn't a key major driver.
I think in my mind, that's reassuring that it's maybe not pertinent because it's not a driver in the model. So that's helpful, unless anyone from the clinical expert side or anyone wants to make any other comments about that. Seeing none, I will transition to Dr. Kogan, who has a question.
Great, thanks. Very clear explanation of the modeling and interpretations. It was great to read and easy to read. Nice work by the team. My question is about the thought process around the discontinuation rates for the medications. And maybe the thought process around incorporating real world non-adherence, non-persistence into the modeling. In the Katie trial, about half of patients had stopped persisting by 6 months, which, you know, if we look at discontinuation from clinical trials where people are followed and, you know, there's more support for medication taking, those discontinuation rates would be lower. So presumably this would be more favorable to KarXT if there was more discontinuation for alternatives and people were able to persist on this longer. And maybe the cost effectiveness ratio would be even more favorable. So just wanted to maybe get a sense of your thought process around how you know, you thought about discontinuation and if there was a consideration to include real world adherence rates.
Yeah, discontinuation was something we put a lot of thought in and had conversations with clinical experts because, as you're mentioning, there was a lot of variation in the inputs used for discontinuation. There were some that were very, very high, but say those were only looking at, you know, first part on treatment, and then there were some that were lower. So we did have conversations with clinical experts and our health economic expert for this review as well, having them kind of give a second look at those discontinuation probabilities. We do vary them widely in sensitivity analyses as well. But yes, discontinuation is high. I mean, I think average time on treatment is only a couple years for these. And so this will be an important area for further work. But the differential effect of discontinuation from KarXT to aripiprazole, I'm always thinking about like what drives the model. And so, you know, if maybe discontinuation is universally too low that was modeled or universally too high, I'm always looking at the incremental component. And so the incremental component between KarXT and aripiprazole, KarXT was 5.9%, aripiprazole was 5.4%. So the incremental difference wasn't all that large.
And if I could follow up, thanks for that response. I don't know if I get a follow up. I'm taking one. You know, I would suppose the value story for this product would be that people will persist longer.
And when you say persist, does that mean on treatment longer or?
Yes, a better side effect profile may translate to longer time on treatment, less, you know, engagement with the health system to change medication and all of the, you know, just inefficiency that comes with having to change medication every 6 months.
Yeah, I might hand it over to David because and I'd love the clinical team to add some color here because the discontinuation went in the direction that maybe wasn't anticipated.
Yeah, I'm not sure that that's a fair statement of the value proposition, Steve, that as we imagined it, I think we did think that that was likely to happen, that there'd be less discontinuation, but you're not seeing that in the data. And you're not seeing it because over the 5 weeks, it actually had a fair amount of discontinuation. What's driving this being a valuable drug is that people don't develop metabolic syndrome and then diabetes and then have heart attacks and strokes, which is a huge deal. If that's right, that's a really big deal. You know, yes, we have lots of uncertainty about that, but the metabolic syndrome caused by the second generation antipsychotics is a big negative deal. And so not having that has a lot of economic value and a lot of value to patients.
So I was just going to follow up on the first point that Dr. Wren made, that you know, in the randomized trial, there were more discontinuation rates with KarXT than placebo. And in our network meta-analysis, so indirect comparisons, the trend was always towards higher discontinuation rates with KarXT compared to any of the 3 comparators that we included in the network. So really not evidence that net you're going to see less or greater adherence, though huge uncertainty because maybe that was just in the acute setting and long-term we'll see something different. So I just think it's an area of great uncertainty still.
Any other, I don't see any hands up. Is that correct?
I'll raise my hand.
Okay, Dr. Pearson, go ahead.
I'll just take the prerogative since we have a little bit of time. I was actually going to ask Mark and Arun and the clinical experts. Mel, if you don't mind putting back, if it's possible, to put back up that slide with your sensitivity analysis results that highlighted tardive dyskinesia and metabolic syndrome and how much the cost effectiveness results changed. People probably remember that if you can't put the slide back up. So I was going to certainly invite the clinical experts. I know that, I mean, you can comment on the evidence as we have it. You can comment on what you know about the mechanism of action, but since those are in a sense the two key, we even had that one table that followed that slide, I believe. Yeah. So you can see the no risk of tardive dyskinesia makes the value improve tremendously. And even if there's a small risk of metabolic syndrome, therefore, any above 0, I'm guessing, compared to the usual population, it makes the cost effectiveness much worse. And that's just to David's point as well, that metabolic syndrome is one of the at least 2 key factors here. So I'd love to invite our clinical experts to comment on this element, both from the data and from their clinical perspectives, and welcome the patient experts also if they have any specific views of the value to patients of these 2 particular features of treatment for schizophrenia.
Just a couple of comments regarding the risk of tardive dyskinesia. If this compound is showing signs of Parkinson's syndrome, that tends to be a harbinger of tardive dyskinesia. So I'm not at this point convinced that this compound will avoid the risk of tardive dyskinesia just based on the presence of EPS in the 5-week studies. Regarding the potential benefit for less metabolic syndrome, in the NIMH CAMP study, comparison of antipsychotic metabolic properties, where we compared several compounds to Abilify. If the switch could be made successfully, it would improve the metabolic status of patients. The problem was there were high discontinuation rates because, big guns have bigger side effects and the smaller guns have, fewer side effects. And the advantages of a compound in terms of metabolic neutrality may be outweighed by an increased risk of discontinuation. So those would be a couple of thoughts and concerns.
Thanks. Vin, anything you'd like to add?
Sorry, I don't know if you were asking me. I agree with everything Steve said. I would just say that in terms of the valuation of bad things, I think tardive dysmetabolism is much better than tardive dyskinesia. And so, it's a trade-off, but one in which the dysmetabolism actually causes premature mortality and is really a big problem in the long run. Whereas Parkinsonism and TD, I think they are distressing and can be disabling, but have rightfully waned in their importance in light of the newer medications. So yeah.
Okay, thank you. Mark or Arun, if you have anything to add, please.
I was just going to highlight. Oh, go ahead, Mark.
I was just going to say, my son has experienced periods where he's had, tremors in his hand and sort of leg movement associated with some of the medications. It absolutely is something that, he's sensitive to and kind of has something to do with his willingness to comply. But it's not been overwhelming in our own experience.
I just want to say kind of on the kind of effect, these side effects can really take such a huge toll on our community. And what I just wanted to highlight, in addition to what others said, is that they really do cause people to stop taking medication. Symptoms like tardive dyskinesia, like weight gain, like metabolic syndrome. In one of the studies that we did a while ago, we found that it's one of the key reasons over 80% of people report switching because of undesirable side effects of schizophrenia medications. And so these are really important considerations.
Great, thanks. Jason, over back to you.
Yeah, I think, this is a super helpful conversation. I think is really kind of helps us really understand the patient experience in terms of the side effects of these medications. So thank you again to the economics team. That was a fantastic presentation. I think we are a couple minutes ahead, but we'll take advantage of that because we sometimes get behind later. And we will